Alright guys, let's get to business here. This is a very important section in your book because it summarizes how to recognize side effects and how not to kill patients. Let's get going with toxicities and side effects. Rarely will the question ever be as simple as toxin and treatment. Most vignettes will expect you to determine the substance the patient ingested and then answer a question related to the mechanism of toxicity or the treatment. Now, a lot of these are super high yield because ingestions are very common, and these types of patients tend to present with altered mental status. If the patient is altered, you cannot ask any questions, which makes you have to connect physical exam with pharmacology, which is why test question writers love this stuff, because understanding how to prevent a patient from dying is high yield. So let's start with the number one most common cause of acute liver failure in the United States, and that is acetaminophen overdose. Now, whether it's suicide or someone accidentally taking too much for pain control issues, you should probably be on the lookout for this on your exams and in real life. It happens. Acetaminophen is broken down by CYP450 enzymes in the liver to a very toxic metabolite called NAPQI. Now, NAPQI is very electrophilic. It loves electrons, and it will steal them directly from hepatocyte membranes and proteins if possible. Now, our body is ready for this, thanks to the electron donor glutathione. Here it is in its reduced form. In its reduced form, glutathione sacrifices itself to neutralize this toxic metabolite, NAPQI, in the same way it would for other toxic molecules like hydrogen peroxide. Now, in the situation of an overdose, the limited amount of reduced glutathione becomes a problem when compared to the amount of NAPQI that we have. After depleting all available glutathione, NAPQI causes oxidative damage. This includes things such as lipid peroxidation. Now, lipid peroxidation irreversibly damages hepatocyte membranes. So what's the treatment for acetaminophen overdose? N-acetylcysteine. N-acetylcysteine replenishes glutathione back to its reduced form. Now, how are you going to recognize this in a vignette or a real patient? Look out for a vignette about a suicidal patient or potentially even a chronic pain patient presenting with nausea, vomiting, elevated liver enzymes, particularly AST, ALT, and maybe even T-bili, total bilirubin, if hepatocyte damage has really progressed. Now, in the presence of a permanent acetylcholinesterase inhibitor, such as an organophosphate, will there be an excess or limited amount of acetylcholine in the synaptic cleft? Well, there's going to be an elevated amount of acetylcholine, which is why we give the muscarinic antagonist, atropine, to compete with all of the excess acetylcholine at muscarinic receptors. You can also give pralidoxime. It's given to help pull the organophosphate off of the acetylcholinesterase enzyme. Now, physostigmine is a temporary acetylcholinesterase inhibitor. It prevents the breakdown of acetylcholine into choline and acetic acid. Now, why in the world would we want to give this drug? It sounds dangerous, right? Yeah, usually making more acetylcholine available in the synaptic cleft makes everyone uncomfortable, but not in the situation in which there is another drug around that is binding and blocking acetylcholine receptors, such as atropine or benztropine. Notice how both of these drugs end in tropine. It's a good way to remember them. Physostigmine inhibits acetylcholinesterase and allows us to have more acetylcholine available to compete with these drugs at the cholinergic receptors. The same concept applies to a different place in the brain responsible for thermoregulation, which is the anterior and posterior parts of the hypothalamus. These two parts communicate with each other by releasing acetylcholine. They do this to make sure that our body temperature is appropriately regulated. If there is an antagonist floating around like benztropine, you need to increase the available amount of acetylcholine to displace it and allow the hypothalamus to function normally in preventing hyperthermia. This is an important drug for you future anesthesiologists out there, and basically for everyone taking step exams. We talked a lot about the mechanism of amphetamines and salicylates in the pharmacokinetics section, so let's use this as a speed drill. Quick recall of the antidotes. What's the antidote or treatment for each? Remember, salicylic acid in its uncharged form exists like this. This is a weak acid. You need to provide a proton acceptor like sodium bicarb so that in the urine, the bicarbonate here will be able to neutralize itself by binding this proton, and therefore we are left with this negatively charged salicylate. Remember that charged molecules cannot cross renal tubular epithelial cell membranes, so the salicylate is going to be stuck, bound to water, and eliminated in the urine. Now tricyclic antidepressants and amphetamines, these are different. These are weak bases. They are treated in a different way. Remember, TCAs can block sodium and calcium channels in the heart, leading to prolonged depolarization of phase 0 and 2. This can show up as a prolonged QRS complex on ECG. So if you're given a vignette that includes an old lady with a long history of depression and an abnormal EKG, you should probably think TCA toxicity and quickly think about acidifying the urine with ammonium chloride. Same thing goes for amphetamines. You also use ammonium chloride. Now benzodiazepines, they bind to the GABA receptor and lock it into a more appealing conformation so that GABA is more likely to notice the receptor and bind it more often. So with that in mind, we can answer this question. Do benzodiazepines increase the frequency or increase the time that the chloride channel is open? Frequency, because benzos make the GABA receptor more attractive for GABA to bind it. This means GABA will bind more frequently. What drug increases the duration of time that the channel is open? These are your barbiturates, or barbs for short. Now you treat benzodiazepine overdose with flumazenil. It directly competes with benzodiazepines at the GABA receptor. 84% of beta blocker toxicity is related to accidental ingestion. This means that your vignette is most likely going to be an accident, right? A kid got a little curious, thought maybe this was some candy, ate a lot of the parent's beta blocker, right? That's how it goes. Understanding how glucagon is the remedy or antidote relates back to those G proteins that will haunt you if you don't learn them. What beta blockers do is that they block the beta-adrenergic receptor, leading to a decrease in the stimulation of the G stimulatory protein. This drops the activity of adenylyl cyclase, which means that we have less levels of cyclic AMP inside the cell. Now glucagon reverses this by stimulating the glucagon receptor. It has its own G stimulatory protein, and activity will be increased. It will replenish the amount of cyclic AMP within the cell and help normalize cyclic AMP levels that dropped from this initial beta blockade. Because beta blockade depresses the sympathetic nervous system, particularly on important organs like the heart, we often give atropine to also antagonize the parasympathetic output on the heart, and therefore these can kind of cross each other out. In your vignettes in real patients, exposure to carbon monoxide has to be associated with things burning or blowing up, some sort of combustion. Look out for someone that was in a house fire, using some sort of gas engines or grills, maybe someone grilling inside, poorly ventilated areas, presenting with an abnormal neurological exam, altered mental state. It's important to remember that pulse ox, when you put the thing on their finger and it reads how much oxygen is in their blood, it will show nearly 100 or 100% oxygen saturation, even though the patient is actually showing signs of end organ hypoxia. This is confusing. Why is this happening? Pulse oximetry uses light wavelength to determine the levels of oxyhemoglobin versus deoxyhemoglobin in the blood. Unfortunately, carboxyhemoglobin, which is carbon monoxide bound in hemoglobin, absorbs the exact same wavelength as oxyhemoglobin. So if the patient is showing signs of end organ hypoxia, but the vignette still says 100% pulse oximetry, oxygen saturation, it can still be carbon monoxide poisoning. This is why real doctors check a carboxyhemoglobin level to actually see how much hemoglobin has carbon monoxide stuck onto it. What's the treatment for carbon monoxide poisoning? Ah yes, sweet oxygen. Put a mask on the patient and pump their lungs full of 100% oxygen so that the amount of oxygen dissolved in the blood increases and so that more oxygen molecules are available to displace the carbon monoxide off of the hemoglobin and reform oxyhemoglobin. So why do we put them in a hyperbaric chamber? The increase in pressure forces more oxygen molecules into the blood, so the O2 dissolved increases. This way that the tissues can actually get more of their oxygen requirements while we're changing the carboxyhemoglobin also into oxyhemoglobin. Copper, arsenic, gold, lead, mercury, and iron, let's group all of these heavy metals into one because all heavy metals can be neutralized by chelators. Chelate is Latin for claw. Now chelators find a heavy metal, any of these, and bind to it like a death claw. The type of chelator depends on the chemical properties of each heavy metal. So dimercaprol and dimercaptosuccinic acid, also known as succimer, these are mercaptans. They were literally named and designed to capture mercury. So these are great for binding mercury. They can also be used to chelate arsenic, gold, and lead. Now copper is classically chelated with penicillamine. And what disease are you worried about copper levels with? Wilson disease, high yield. Now gold, not very high yield. It can be chelated with anything. Not many people are accidentally ingesting gold. Lead is probably the most high yield of any of these because it is easily absorbed through the skin and also through the lungs. Lead is involved in the making of paint, batteries, and also moonshine. So when you're thinking about the vignette, look for industrial workers, drunks, and people that live in a house that was built before 1970. That's when they outlawed the use of lead paint in homes. Again, you can technically give any of these chelators, but traditionally EDTA has been used for lead poisoning. More importantly for you it is to recognize the lead poisoning than it is to know how to treat it. Now iron, Fe, in Latin is called ferrum. Notice how all of the chelators, deferoxime, deferracerox, deferriprone, all conveniently have Fer in the name to help you recall these are chelators that bind ferrum, also known as iron. Now let's get to cyanide poisoning. We saw this in the cardiopharmacology section when describing the toxicities of giving too much sodium nitroprusside. Cyanide is very electronegative. It's looking for a very positively charged thing, kind of like the Fe3+ ferric iron of complex 4. Complex 4 is also called cytochrome C oxidase because it oxidizes cytochrome C because it makes it lose electrons. This integrates biochemistry, so focus in here. Complex 4, remember, usually accepts electrons from cytochrome C, but cyanide can slip in here and then bind this ferric Fe3+ iron. It likes this component of complex 4. This obviously interrupts the electron transport chain because things cannot pass electrons. Cytochrome C is unable to pass electrons down the electron transport chain because cyanide is inhibiting complex 4 from accepting any. Now one of the options to treat cyanide poisoning is to directly bind the cyanide. We can do this with hydroxocobalamin. The negative hydroxyl groups from the hydroxocobalamin will just do a quick switcheroo and these things will be switched over and now we create cyanocobalamin. Another more complicated and therefore more highly testable method of treating cyanide toxicity is to induce methemoglobinemia. I know this is painful, but this is important. This is a heme group. There are 4 heme groups like this one in the hemoglobin molecule. As we see here, normal hemoglobin has an Fe2+ ferrous iron in the protoporphyrin ring. We can give sodium nitrite to steal an electron away, making this now Fe3+ ferric iron in the protoporphyrin ring. Why are we taking perfectly good hemoglobin and turning it into this junk? Remember, we said that cyanide is interrupting cellular respiration because it loves to bind to Fe3+ ferric iron of complex 4. So by inducing methemoglobinemia, we are essentially creating a ton of decoy binding sites so that now that cyanide will tend to bind to methemoglobin instead of complex 4. The last part of the treatment is to give thiosulfate. Well, it's going to steal the cyanide off of the methemoglobin to make thiocyanate. Okay, in the last situation, let's say we accidentally give the patient too much of the oxidizing agent, the sodium nitrite. And now the methemoglobin levels are through the roof. Oops, we did too much good. What is the treatment for methemoglobinemia? How about methylene blue and vitamin C? That's so random. How are you going to remember this? Remember, the problem in methemoglobinemia is that the iron in the protoporphyrin ring of hemoglobin is now in an Fe3+ state. So we need some electron donors. These guys are going to donate their electrons and turn our iron back into Fe2+ iron, Methylene blue and vitamin C. These are highly testable things because they test your understanding of the mechanism of methemoglobinemia and how we fix it. Oh my god, this is incredibly high yield. Focus in. No, seriously, these are high yield. All alcohols, ethanol, methanol, propylene glycol, ethylene glycol, these will be broken down by alcohol dehydrogenase with the help of NAD+ into its corresponding aldehyde, which will then be converted into a corresponding acid by acetaldehyde dehydrogenase, again using another NAD+. Important, important, important. It is not the alcohols that cause the problems unless someone's a drunk ass, which is ethanol. It is when the alcohols are metabolized into aldehydes and acids that we get these problems that kill people. Now, you can treat overdoses on these alcohols by preventing these two enzymes from creating those harmful aldehydes and acids. We don't want these. How do we inhibit alcohol dehydrogenase? Fomepizole. Two important ones that are highlighted in this section are methanol and ethylene glycol. So let's start off with methanol. Who drinks methanol? Poor drunk people, right? It'll get you drunk. You can buy methanol for cheap compared to ethanol. Methanol is converted into formaldehyde and then formic acid. Formic acid is toxic to the retina, which can actually lead to complete blindness. If you don't have any fomepizole laying around to inhibit alcohol dehydrogenase, well then you have to give something else. What is that? You can actually give ethanol because it'll compete with methanol at alcohol dehydrogenase binding sites. Remember, we do not want the metabolites of methanol, particularly formic acid, to be formed, so we have no problem keeping methanol in its alcohol form. Who drinks ethylene glycol? Kids. Kids creeping around under sinks or in the garage who think that antifreeze is Kool-Aid. But guess what? Oh no, not oh yeah. The ethylene glycol is going to be metabolized all the way into oxalic acid. Oxalic acid binds calcium in the renal tubules and can precipitate into crystals within the lumen of the renal tubules. This will block outflow and cause acute renal failure requiring dialysis. Now we get to one of the biggest problems in the United States today, opioids. These are a huge problem in the USA, so you better know everything about them. Now watch out for the IV drug user, particularly heroin, or the chronic pain patient that's taking too much oxycodone or whatever favorite cocktail of medications that they've been put on for their chronic pain. How are you going to know if someone overdoses on opioids? The number one best sign in an adult is a respiratory rate less than 12. This has to be in the vignette to give you some sort of tip-off. Breathing mechanisms are important in understanding opioid respiratory-induced depression. In addition, you will most certainly be described a patient with miosis or small tiny pupils, altered mental status, and maybe even low blood pressure, hypotension. So why is there hypotension? Opioids induce tons of histamine release from mast cells. This is an interesting thing to consider because of the massive vasodilatation that occurs from the histamine release. Some patients may actually even have a lot of itching or pruritus because of this massive histamine release requiring Benadryl before they get their pain medications. Okay, phew. Finally, we get an easy one. The treatment for digoxin overdose is to give anti-digoxin fragments, right? FAB stands for fragment antigen binding. These little molecules are specifically designed to seek out and bind up all available digoxin. Now what about TPA, streptokinase, and similarly urokinase? Recall that tissue plasminogen activator, streptokinase, and urokinase all activate plasminogen, the zymogen, into plasmin, which is the active form. Now plasmin is responsible for fibrinolysis, for breaking up the fiber mesh and creating fibrin degradation products. Let's say your neighborhood stroke neurologist gives way too much TPA, got a little trigger happy. How would he reverse his mistake? Aminocaproic acid. It literally mimics the binding site on plasminogen so that TPA will preferentially bind the aminocaproic acid instead of binding the plasminogen. Now we get to warfarin. This is so important. You must know how to properly anticoagulate your patients, no matter what kind of doctor you are. Now, warfarin is a small, fat-loving molecule that can easily cross membranes, including membranes of the placenta. Warfarin works by inhibiting vitamin K epoxide reductase. Inhibition of this enzyme prevents the formation of reduced vitamin K. Without any vitamin K in its reduced form, gamma glutamyltransferase cannot work. It's lacking its cofactor required in the production of clotting factors 2, 7, 9, 10, and the two proteins C and S that counteract clot formation by cleaving activated factors 5A and 8A. Now, a great way to reverse the effects is just to give reduced vitamin K, right? Replace what you lost, replace what you depleted. Why isn't that enough if someone bleeding on the table is right in front of you? This is a big thing in medicine, time. The vitamin K just won't get the job done in the acute setting because it will take time for the liver to use the newly available vitamin K to synthesize new vitamin K dependent clotting factors. If you're missing it, you got to remake it. No time for that. So what do we do in addition to give vitamin K? Well, we skip this whole process and we go straight to say, hey, we'll give you what you're missing. We give fresh frozen plasma FFP. It has all the clotting factors that we need in the acute setting.